Hello, I'm Dr. Samuel Frank, and today we're going to be talking about assessing and documenting disability in Huntington's disease. These are my disclosures. There are 4 learning objectives for this module. The first is to understand the Social Security Administration definition of disability and the basic eligibility requirements of SSDI and SSI, and we'll go into the acronyms in a few minutes. 2, understand how to assess and document the motor, cognitive, and psychiatric symptoms of Huntington's disease for disability purposes. The third is to understand how to assess an individual's HD stage and functional decline using the Scholzen-Fawn Total Functional Capacity Scale, or TFC. And finally, to understand how to assess and document mixed dementia using SSA compassionate allowance criteria. These are the key points for this module: that Huntington's disease is more than chorea. Disability may or may not be related to the movement aspect of Huntington's disease. Because of this, it's really important to document all symptoms of Huntington's disease as early as possible, and this is key for getting patients on disability. I just want to take a step back here for a minute, because this module, some people say, disability, we don't need to know about it, but physicians can have such an impact on patients and their families when they know how to document and what to document. Not just the movement, but every aspect of Huntington's disease. And when you fill out the forms right and you understand Huntington's disease, you make a tremendous difference in people's lives. So in documenting, you want to document the total functional capacity, because this is the primary tool that we use to quantify function, and it's also used to stage Huntington's disease. A definitive diagnosis of Huntington's disease, in other words, not suspected Huntington's disease, is necessary to receive disability for HD. So you want to clearly document that in your notes. Individuals who do not have a definitive diagnosis for Huntington's are routinely denied, and this is a major issue when people are clearly symptomatic and have the disease. In terms of disability and Social Security Administration definitions, disability is the inability to do substantial gainful activity due to the severity of an illness in accordance with the listings set forth by the Social Security Administration in the Blue Book. So this is the standard that people use to judge disability for every disease, not just Huntington's. Huntington's is a progressive brain disease, so every individual with Huntington's will eventually lose their ability to perform substantial gainful activity. Individuals who lose their ability to work due to Huntington's cannot be retrained or cannot be retrained for a new occupation. There are 2 programs. There's the Social Security Disability Insurance, or SSDI, and Supplemental Security Income, or SSI. Individuals are automatically evaluated for both SSDI and SSI. The medical eligibility for both is the same. People ask, what's the difference between SSDI and SSI? And SSDI, the Social Security Disability Insurance, pays benefits to patients and certain members of the family if they're insured, meaning that they've worked long enough and have paid Social Security taxes. Generally speaking, people need about 40 credits or 10 years of work to qualify for SSDI benefits. Younger people may need fewer credits. People who become disabled before 22 may also be able to receive disability insurance benefits if they have a parent who dies, retires, or becomes disabled. So that's SSDI. SSI pays benefits to patients and certain members of their family if they have limited income, assets, and meet certain living arrangement requirements and are otherwise eligible. Becoming eligible for disability, individuals can qualify when their Huntington's disease is severe enough to prevent them from being able to engage in work activity. Generally speaking, this is when people transition from stage 1 to stage 2 on the TFC scale. And they are also eligible when it's lasted 12 months or more and is expected to last 12 months or more. Huntington's disease is a progressive disease, so once they've already qualified for disability, it's certainly going to expect to last 12 months or more. The Blue Book, which is the main guide for diagnoses that qualify for disability, does not list Huntington's disease. And there are currently 2 Blue Book sections that pertain to Huntington's disease. The first is adult neurological listings, and this raises motor symptoms. The second is organic mental disorder, and this lists cognitive and psychiatric symptoms. And we'll go into how to list each of these. Importantly, getting back to patients not having worked for 12 months or more and not expected to, that it's expected to last 12 months or more, Individuals don't have to wait 1 year before applying for disability, but they can't be working at the time of the application. A decline in Huntington's disease in terms of the motor symptoms, these are some of the symptoms to pay attention to and document. They're all clearly related to Huntington's disease, and they don't have to be specific to the Unified Huntington's Disease Rating Scale. They can be assessed outside of that in addition. Gait disorders are often impacted by Huntington's disease. Speech, including dysarthria and loss of regularity of speech. Eating and swallowing can be very much impaired. And common involuntary movements that are associated with Huntington's disease that should be documented include chorea, dystonia, bradykinesia, which you have to take a step back and watch a lack of movements, rigidity, myoclonus, tremors, and tics. In terms of assessing and documenting the motor symptoms, you want to focus on Huntington's disease, but you also want to include a general neurological examination. Eye movements are part of the Unified Huntington's Disease Rating Scale. Muscle stretch reflexes are not. Those can be dramatically increased in people with Huntington's disease. Coordination, again, is not part of the Unified Huntington's Disease Rating Scale, and people can have ataxia or incoordination. Gait, there's one measure on the Huntington's Disease Rating Scale, but you can document gait a bit better and a little more detail as part of the general neurological examination. The focus on the motor portion should include assessment of spontaneous movements, observation of involuntary adventitial movements, tone, bulk, and strength. The Unified Huntington's Disease Rating Scale, specifically Part 1 that focuses on motor, does require some training to administer consistently, but if you know how to document this and assess people, it's always helpful to have that as part of the assessment. In terms of decline in HD related to the cognitive symptoms, there's a large number of cognitive symptoms, as we've heard in other modules. There can be perceptual problems in terms of emotional recognition. People may not recognize anger or happiness. There's a poor perception of time, spatial perception, smell identification, and a general unawareness, which we're going to go into a little bit as well. Executive decline obviously has a significant, much more significant impact on people's higher functioning jobs. Cognitive processing, attention, planning and organizing, apathy, perseveration, and impulsivity. All of those can have an impact on a person's functioning for work. Learning and memory problems, of course, can happen, and this is more in the implicit memory, but also recall. Language, people can have impaired initiation of speech and maybe a step behind others. And there can be disorganization of language content. In terms of assessing the cognitive symptoms, standard bedside testing is usually adequate. The Montreal Cognitive Assessment is widely available in multiple languages and is a good bedside assessment that only takes about 5 minutes. Many people use the Folstein Mini Mental Status Examination as well. That's a little less sensitive, but certainly would do. The Unified Huntington's Disease Rating Scale cognitive portion, again, requires some specific training on how to do it, but it's also specific for Huntington's disease. It includes the symbol digit modality test, the Stroop interference test, and verbal fluency. Some patients do need to be sent off for more detailed neuropsychological testing, which can be more sensitive for assessing mood and some cognitive issues, but this requires referral, attention, and a lot of time sometimes. In terms of documenting the psychiatric and behavioral aspects, depression is very common in Huntington's disease patients, up to 50%. Mania, and this isn't necessarily the typical bipolar disease type mania, it can be extreme agitation. The obsessive compulsive disorder and the perseveration, the repetition of various aspects or requests, delusions, and even hallucinations. The dysexecutive syndrome or frontal lobe syndrome of unawareness and apathy in particular can be particularly problematic. In terms of irritability, it can, people can have a lack of emotional control and can feel overwhelmed very easily, resulting in a sense of and behavior of irritability. Other issues that sometimes happen more in moderate to advanced stages but can be an issue when thinking about applying for disability include delirium, anxiety, a general sense of agitation, sexual disorders, and sleep disorders. In terms of documenting the psychiatric symptoms, this is usually assessed with a caregiver with the patient as well, and in the setting of the history of present illness. The Unified Huntington's Disease Rating Scale behavioral section may be undergoing some modifications, but it can be used to help support the behavioral aspect of Huntington's disease. And it's very important to document any suicidal ideation. Anosognosia is, I want to take a minute to highlight this because this is often a significant issue in people with Huntington's disease. They may not be aware of their cognitive, behavioral, or motor issues. And this can result in minimization of symptoms and minimization of their decline. It's not related to denial of the disease. It's separate. This is due to deterioration of the brain. Patients can have denial as well, but it's separate from this unawareness of the disease. The person with Huntington's might still be able to identify problems they're having, but may be unaware of the cause. So they may say, I don't have Huntington's disease, or my coordination is bad and I have fidgety movements, but it's not related to Huntington's disease. They may also recognize that they're knocking things over, but not see that it's related to chorea, for example. And so when you talk to them about their symptoms they may be having, if you can pinpoint a particular symptom rather than just chalking up to Huntington's disease, you can get through to the patients a little easier. You also can get a much more accurate picture of the symptoms, the impairment, if the caregiver is asked to provide some information. So I may ask someone, do you take care of yourself? And the patient would say, sure, I can do buttons, I tie my shoes, I put on belt buckles, I can shower myself, and the caregiver behind them is going, no, I help. So you really need to get the person, the caregiver, involved in many of the assessments related to function in particular. So some of the key points related to disability, the cognitive, motor, and psychiatric changes may impact functioning early in the course of Huntington's disease. It's key that individuals have documentation of this decline related to Huntington's disease symptoms. And it's also important that they don't apply too soon. So in terms of documentation, this can happen even years before they develop disability, but to document that it's there is really important from the physician side. Individuals must have a definitive diagnosis of Huntington's disease. Don't hedge. If they've got the disease, write it down. Individuals do not have to wait the 12 months before filing for a disability claim, but they cannot be working when they apply for disability. Individuals who are unable to work because of Huntington's disease cannot be retrained for another occupation, and this is also important to document and note. And very key in terms of assessing the patient, the caregiver should be consulted to corroborate with patient and to reinforce any statements or to go against what the patients have stated. The HD Staging and Function Scale is the Scholson-Fawn Total Functional Capacity Scale, or the TFC. And when patients ask what stage of disease I'm at, this is what we use. It's really looking at the function, and we're going to go into some detail about how we get to the total. But stage 1, individuals may be functioning close to normally or more likely having substantial difficulty at work or unable to perform the usual job at premorbid levels. This is particularly true when they start to get symptomatic and are at 11 or 12. They can be 13 and pre-symptomatic. Stage 2, the transition from stage 1 to stage 2 is an important one in terms of function. Usually in stage 2, individuals are unable to work at any job, and they often lose their ability to drive safely as well. They are struggling to maintain independence and perform ADLs. And so this is really where patients at this stage and worse are going to be thinking about stopping work and applying for disability. In stage 3, individuals begin to require active supervision, can't remain at home alone, and ultimately need 24-hour care. Patients can be in stage 3 and below for many years. Stage 4 and 5, patients generally need full-time care in a nursing home or the equivalent. And again, patients can be at stage 0 even for many years. This is what the 13 points is made up of. It's 5 different assessments: occupation, finances, domestic chores, activities of daily living, and care level. And we're going to go into each of these in a little bit of detail. Again, the caregiver really needs to be involved in the assessment of each of these aspects of the patient's function. In terms of occupation, this is from 0 to 3. 3 is normal. They're able to do what they normally do. Grade 2 on occupation is reduced capacity for their usual job. There may need to be some adjustments. Perhaps they've gotten a different job within the same company, or even a different job with reduced capacity. A grade 1 on the occupation is marginal work only, and 0 is unable. On the finances, this is also 0 to 3. 3 is normal. 2 is slight assistance, so perhaps they're not making major investment decisions, or they're not paying bills. Somebody else is doing that. Major assistance means that they handle money to go buy something at the corner store, but they're not writing checks or making financial decisions for the household anymore. And 0 is that they don't handle money at all. Domestic chores is 0 to 2, and this is normal, impaired, or unable to complete at all. And on the ADLs, patients, this is again from 0 to 3. 3 is normal. 2 is minimal impairment, so perhaps they need help with buttons or tying their shoes. Grade 1 is gross tasks only, so they can get their shirt on, they can get their pants on. That's really about it. They need help with everything else. They need help showering. So this is the type of questions that you want to ask when you're assessing activities of daily living. And care level is either at home. This is a 0 to 2 scale. It's either at home, home or chronic care, and this is where someone might need 24-hour supervision, for example, but can be at home and may have some functioning around the house. And grade 0 is full-time skilled nursing. It's helpful if physicians would use the total functional capacity at each appointment as a tool to document their progression. It's easy. It only takes a few minutes to assess their functioning. There are questions that you're probably going to want to know anyway. The SSA prefers scaled, relatively objective measures, highlighting the need to document a total functional capacity. In the early years, people generally lose about 1 point per year, and then it starts to taper off down to about half a point per year. But it's pretty consistent that people lose half a point to 1 point per year on the TFC. Most people with Huntington's are unable to work and apply for disability when they reach stage 2, but there are individuals that require a high level of cognitive skills or processes that become disabled even in stage 1. But again, it's important to talk about that and document that, or even put why you're giving them points off in the TFC. The TFC is one part of the tool of the Unified Huntington's Disease Rating Scale, and there are other measures of function in that, but it measures motor, cognitive, and psychiatric symptoms of Huntington's disease. And again, because of this lack of insight, caregivers should be consulted to corroborate what the patients are saying about their function. I'm going to talk a little bit about the Social Security Administration's Compassionate Allowance Program. It's the fast-track designation to rapidly identify medical conditions that invariably qualify for Social Security disability. So you would think that Huntington's disease, it'd be a no-brainer. But under the Compassionate Allowance program, Huntington's disease is not part of that list. It's not one of the 113 conditions. And so we have to list it as a mixed dementia. Certain people with Huntington's can qualify for this because they meet the SSA criteria for mixed dementia. Juvenile onset Huntington's disease will become a compassionate allowance condition in August of 2012. The information about compassionate allowance designation for JHD should be noted prominently in the medical records. Individuals with adult onset Huntington's should be evaluated for mixed dementia, and something as simple as the Folstein Mini-Mental and Montreal Cognitive can support this. And an individual who qualifies for disability under the mixed dementia can potentially receive benefits much faster than they would otherwise. Unfortunately, as of June 2012, Huntington's disease is not included in the Compassionate Allowance Program. In terms of the mixed dementia SSA criteria, it refers to dementia brought on by multiple causes. Huntington's disease can be one. They're characterized by progressive and persistent intellectual decline, compromising at least 2 spheres of cognition. So that can be memory, language, orientation, attention, executive abilities. Again, these are measures that are all assessed on the standard bedside measures of cognition. Individuals can also have motor and gait impairment that can impact their cognitive, sleep disturbances, and incontinence. These all can add into the diagnosis of mixed dementia under SSA criteria. It should be noted prominently in the medical record. In terms of some suggested medical evidence to document for mixed dementia, many people are familiar with the Clinical Dementia Rating Scale. By definition, a 0.5 is mild cognitive impairment, so cognitive impairment that does not result in functional decline. If you document dementia and cognitive decline that causes functional impairment, by definition they have clinical dementia rating scale of 1. The mini-mental status examination score of 20 or the equivalent test such as the Montreal Cognitive is helpful and suggestive of dementia, but it's not required. Again, the activities of daily living report completed by a caregiver or relative, and this is something hopefully you're going to do anyway as part of the total functional capacity. Work activity or performance report completed by a supervisor or coworker can be suggestive evidence as well. Neuroimaging studies are not necessary, such as MRI or CAT scan, but if there's atrophy, it can be supportive. Again, these are not necessary. I just want to review some of the key points so far. If an individual meets SSA criteria for mixed dementia, it should be noted prominently in their medical records. Right now, mixed dementia is the only compassionate allowance listing that applies to Huntington's disease. Juvenile onset Huntington's will become a compassionate allowance condition in August of 2012, and HDSA is working with SSA on a separate compassionate allowance listing for Huntington's disease in terms of the adult onset. HDSA is working with SSA to streamline the disability application process for HD and developing a toolkit to help professionals document disability. If you're working with an individual who fits SSA eligibility criteria for Social Security disability, but the application was denied by Disability Determination Services, please contact HDSA at hdsainfo@hdsa.org. HDSA will be in touch with you as more information becomes available. So I just wanted to thank everyone for attending the CME series on Huntington's disease. We hope that you have found it helpful, informative, and that it stimulated your interest in Huntington's disease. This series will be available on the HDSA national website as a continuing activity, and please feel free to use the series as a reference tool when you come across patients with Huntington's disease. If you have any further specific questions that were not addressed during this series, feel free to email hd101@hdsa.org.